Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Lung cancer is Australia's deadliest cancer. When patients develop symptoms like coughing, it is generally no longer curable by surgery or other treatments. But what if this cancer could be detected early through a government-backed nationwide screening program like we do for breast or bowel cancers? Our guest today said it could push the cure rate as high as 90%. To tell us more, I'm joined by Professor of Respiratory Medicine at Macquarie University Hospital, Alvin Ing. Professor Ing, how important is a comprehensive lung screening program in early detection and improving patient outcomes?
So the issue of lung cancer is that it's not the commonest cancer, but it is the most deadliest cancer. And of all the solid organ cancers, lung cancer is most deadly. And the reason why the mortality is so high is because of late presentation. So by the time you get symptoms like cough or hemoptysis or chest pain, the lung cancer is often incurable. So the whole point of lung cancer screening, as with other screening programs, is to be able to detect the cancer early before it's symptomatic, and before it progresses into more advanced stages, so you can realistically offer a cure before symptoms develop. So lung cancer screening program, which will be coming into Australia in July next year, that's what it's designed for early detection and improving the survival rate of lung cancer, which is pretty abysmal.
Most people would associate lung cancer detection with a chest X-ray. How effective is this in detection?
Well, a chest X-ray unfortunately doesn't pick up early lung cancer. The problem with chest X-rays is it doesn't pick up small lesions, ground glass lesions, which you can't detect on X-ray. And often the chest X-ray will hide lesions, behind the heart or, things that are close to the mediastinum. So the recommended technique for lung cancer screening is an ultra low dose CT scan.
How is this scan different?
It's a CT scan. So basically, the CT scans have been in existence for 30 years. But this is an ultra low dose CT scan to minimise the radiation risk to the individual. Given the fact that if you find nodules, you're likely to need follow-up CT scans in the future. So you really want to minimise the radiation dose, and the ultra-low-dose CT scan minimises radiation dose while allowing us enough resolution to pick up small lesions, including less than 1 centimetre ground glass lesions, which is what we're seeing already. I mean, we're already seeing a lot of these present as incidental nodules, people having CT coronary angiograms, people are having CT scans for other reasons, and these nodules being picked up incidentally. What lung cancer screening does is allow an ultra-low dose CT to target a high-risk population. So it's using an existing tool, but at a lower dose than what you conventionally would do a CT at.
How would people qualify for this type of scan?
Yeah, so this is, some of the logistics still have to be sorted, but the notion would be that symptoms is no longer screening. If you're symptomatic, you're going to present, hopefully, to a GP anyway. The idea is for people to be aware of the program. So if they have the prerequisite conditions, then and if they've got a smoking risk or a smoking history, they will present to the GP, and the GP will be organise a federally funded, Medicare-funded ultra-low-dose CT to screen for symptoms. So this will be funded by the federal government at no cost to the patient, which is absolutely necessary to encourage screening of a high-risk population.
When will people be able to access the scheme, and how will they ask for it?
July next year. So I would envisage, if you want to take an example of what happened, you would have someone in the community who was a smoker. They may have stopped 10, 15 years ago, but they were a smoker for perhaps 20 pack years, and they're worried about their risk of lung cancer. They will present to their GP. The GP will order ultra-low dose CT. The CT result will go back to the GP, and the GP will assess that and determine whether or not the patient's at risk. If the GP is not certain as to what the risk categories of the nodules are, then various places, including us at MQ Health at Macquarie University, have set up a comprehensive lung nodule screening program where the GP can refer the patient or even ring us up to get advice as to what they should do with the nodule. Most nodules probably won't need a lot of sort of investigation. Most small nodules may just be followed up with another ultra-low dose CT scan in a year or two's time. But if they're at high risk, particularly larger nodules, or if they've got certain characteristics, then they will need to be seen, perhaps, and diagnosed, perhaps, is one of the newer diagnostic techniques that we have. But part of a comprehensive lung nodule program which we're developing is to provide this support for GPs in our area.
Will there be an awareness campaign similar to breast cancer and bowel cancer screening?
That's what we're hoping for. So, look, I mean, it's still a year to go, and we're developing that. But from a federally sort of Australia-wide sort of point of view, it has to be excellent marketing. We've got to increase awareness amongst the at-risk population for people to understand what it involves. I think there's pretty good understanding what breast cancer screening is at the moment, colorectal screening, and the same marketing, the same awareness needs to be promoted within the community. And that's sort of the role of the federal government, but a lot of the cancer bodies associated with that as well, including Lung Foundation Australia, Cancer Australia, and we have to work together to ensure that message gets across to the community at large.
With the scan results, how will a GP know the difference between something that can go untreated or needs to be referred for treatment?
So there is a very well documented sort of risk assessment modules for these nodules based on the patient's age, the smoking history, the size of the lesion, the type of lesion, and family history, for example. And you can and there are online calculators. There's a calculator, for example, called a Brock calculator, which associates risk. But we understand that not all GPs will be familiar with that. We also understand that not all GPs will be familiar using a model like that. So that's why local programs such as something that we're developing at MQ Health will allow the GP to call or communicate whichever way they want with our lung cancer clinical nurse consultant, who would have all that information in them. They may be we'll be able to access the images online to be able to help advise the GP if need be. And if the GP deems it appropriate, they can refer to us. But we would aim to provide a support program for GPs in the area or even out of area, where if they're not certain or if they're not sure as to what the implications of a particular finding on CT is, they can sort of call us or email us or use other forms of communication to get some feedback as to what they should do with that patient.
What are the latest diagnostic tools when a nodule is found?
Okay, so I mean, it's likely that most nodules that we find will be low risk, and all they need to be is followed. There'll be some nodules that'll be higher risk because of their shape, their size, their location, or the patient's history, that will need to be assessed and then diagnosed. With regards to diagnosis, the major advancements in that has been bronchoscopic methods of diagnosing it without needing to put a needle through the chest wall. So for many, many years, the way we used to diagnose nodules, particularly peripheral nodules, was transthoracic needle aspiration, which would involve a needle going through the chest wall under CT guidance. And there's significant risk with that. There's the risk of pneumothorax is up to 20% with that. The risk of major bleeds is about 8%. And the major advances that we've had in diagnostics in the last few years is to be able to accurately diagnose this bronchoscopically using robotic scopes, using cone beam CT guidance to reduce the risk of pneumothorax to below 1%, the risk of major bleeds to less than 0.5%, and have similar yields to transthoracic needle aspiration. And that's something that we've been developing and others have been developing in readiness for lung cancer screening, where we'll face an avalanche of nodules that we'll have to diagnose safely, accurately, and quickly.
What happens after this diagnostic phase in terms of treatment, and how does a multidisciplinary team come into play?
So once you've got a diagnosis, then it obviously depends on the diagnosis. Quite a few nodules will be non-cancerous. There'll be some TB, there'll be some hematomas, there'll be some granulomas, and they are either treated medically or just observed. But if you get a diagnosis in a peripheral nodule of a lung cancer, then that needs to be treated. And you then need to assess the stage. So you will do a PET scan beforehand, make sure there was no nodes involved, make sure there's no systemic sort of spread. And if it was a localized lesion without systemic spread, that there were no nodes on a PET scan, then almost all those patients would go for surgery, provided they had appropriate lung function to tolerate that. And the advances in surgery are substantial in recent years, particularly minimally invasive robotic surgery, whereby the mortality and morbidity have significantly improved compared to open procedures and even compared to thoracoscopic procedures. Those that are not suitable for surgery, there's been significant advances as well in stage 1 lung cancer, particularly with SABR, stereotactic radiotherapy, which again gives excellent results in those that are not suitable for surgery. And in those patients that have tumour beyond the lung with nodal involvement, then there's been major advances in immunotherapy, targeted therapy, and chemotherapy as well. So yeah, it's a multidisciplinary approach, and the reason why it's a multidisciplinary approach is because the advances in each discipline has been so quick and it's been exponential that you need the expertise of everyone involved: radiation oncologists, medical oncologists, cardiothoracic surgeons, as well as respiratory physicians and interventional pulmonologists.
How will this change the prognosis for patients diagnosed with Australia's deadliest cancer?
So if you look at the overall survival of lung cancer, it's 20%, which is horrible. The average cure rate, I should say, the average cure rate for breast cancer, colorectal cancer is about 70%. So lung cancer is lagging really, really dramatically. And the whole point of doing lung cancer screening is that if you can detect asymptomatic cancers early, you can offer a cure. The reason why, as I said earlier in the podcast, the reason why lung cancer is so deadly is because by the time you develop symptoms, the cancer is a size, it's at a certain spread, whereby it's no longer curable by surgery, it's no longer curable by combination therapy, and it then becomes a palliative exercise. So if you can detect lung cancer before you get symptoms, that's the whole point of trying to shift the curve to a cancer that has a much higher cure rate than it does at the moment.
If we can catch it early, what happens to the cure rate of those diagnosed?
Okay, so if we can get lung cancer at stage 1, which is basically localized cancer less than 3 centimeters in the lung without any mediastinal nodes, then surgery offers a cure rate close to 90%, so 90% 5-year survival. So it shifts the curve dramatically in favour of survival.
What specific lifestyle intervention and prevention measures should GPs advise to reduce the risk of lung cancer?
Everybody knows of the link between smoking and lung cancer, and that's well established. Plenty of evidence for that, and that's the advice most doctors and GPs would give to their patients to cease smoking. But there's other factors involved which are less obvious, and there is evidence for bushfires and air pollution being significantly related to the long-term risk of lung cancer. There's quite a lot of when the bushfires hit the east coast of Australia in 2019. There were a lot of patients that were concerned about the long-term risk of exposure to small particulate matter, PM2.5s and so on, and the risk of lung cancer. And there is reasonable evidence, both in Australia and overseas, that this has a significant risk of increasing long-term risk of lung cancer. There's also concerns about vaping, and we don't know the long-term effects of vaping in lung cancer. We do know the adverse short-term effects, but the long-term effects of vaping, there's some evidence suggesting that there is a risk to lung cancer, and also air pollution as well. I mean, one of the biggest risks for lung cancer in the less developed world is biomass fuels and cooking over open stoves, and there's very good relationship between that and lung cancer as well. So there's some of the lifestyle things and some of the environmental things that we can sort of do to mitigate the risk of lung cancer.
Can you discuss the role and importance of clinical trials in lung cancer treatment and how GPs can help patients access these trials?
So there's clinical trials in lung cancer in all sorts of areas. I can speak to my area, which is interventional pulmonology, but some of the major advances in clinical trials has been in medical oncology. With the use of molecular analysis of lung cancer, we can basically target certain types of lung cancer with specific medications, specific therapies. These include targeted therapies like for tyrosine kinase inhibitors. This can include immunotherapy. We all know what pembrolizumab has done for melanoma and colorectal cancer now, and it's having a significant role also in immunotherapy in lung cancer. And the advances are not just in therapy and targeted therapy, but when we use them. And there's increasing evidence that if you use them at an earlier stage, it does prevent long-term recurrence. So clinical trials are absolutely critical for that, and the medical oncology clinical trials is at the forefront of that. From our point of view, which is interventional pulmonology, we did the first in-human clinical trial of robotic bronchoscopy called the Galaxy system, looking at accurate diagnosis, and we're about to publish that. We're also just studying a clinical trial to get a first-in-world clinical trial on local therapy of lung cancer. So when we diagnose lung cancer, we put a needle into lung cancer, get the diagnosis on pathology. But at the same time, if this is not now, but in the future, it may be appropriate to treat that at the same time. And we're trialing different forms of therapy, including thermal therapy with microwave ablation, radiofrequency ablation, as well as thermal liquid ablation to locally treat the cancer. And of course, the evidence isn't there as to long-term success and long-term prevention of recurrence. But in patients where surgery may not be suitable, it may be a good therapeutic option to treat it locally and assess its worth. So yeah, that's the role of clinical trials. It's really shifting the landscape of how we manage lung cancer, but of course you need the evidence, and that's what the clinical trials are for, to determine whether something new, something sort of novel is going to be appropriate in the long term for patients.
What effect on stage 3 or 4 cancers do these therapies have?
If you're looking at stage 3 or 4 lung cancer, so stage 3 lung cancer generally is a large primary tumour, often with glands either on the same side or the opposite side of the mediastinum. And in those situations, there's various ways of approaching it. One is called neoadjuvant therapy, where you combine chemotherapy and radiotherapy, try to shrink the tumour down, and then submit them to surgery. The thing with surgery in stage 3 cancer is often not appropriate because it's beyond the boundaries of what you can achieve. But if you can downstage the tumour with a combination of chemotherapy, immunotherapy, or radiotherapy, then you can significantly improve the survival and mortality. And stage 4 tumour, particularly with targeted therapy, we're seeing complete remissions with targeted therapy. It doesn't mean it's a cure, but for example, with EGFR mutations, epidermal growth factor receptor mutations, you can get targeted therapy with that, and even in stage 4 disease, you can get significant sort of responses to that, sometimes complete remission. Again, I say that doesn't mean it's a cure, but these were sort of responses that we were not seeing prior to targeted therapy.
And what message would you like to leave our audience?
The importance, I think, of talking about lung cancer is that lung cancer screening is coming. And I think that the community at large needs to be aware of that because it is a sort of program which costs nobody anything. Well, it costs the government, but it doesn't cost the patient anything. And if you can pick up a lung cancer early and treat it, then the survival from the most deadliest lung cancer will significantly improve. And it's, I think, important to get that message out to the community and also to GPs to realise that, one, the program is coming, and secondly, the aims of the program is to really address a issue that should have been addressed a lot earlier.
My special guest has been Professor Alvin Ing from Macquarie University Hospital, part of MQ Health, the sponsor of this podcast. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.